Great, thank you. Thank you very much, Bobby, and thank you to the SMSNA for organizing this webinar series as part of the SMSNA Fellowship Program requirements. We're very happy today to be joined by Jason Kovac from Indiana, and I am a reproductive urologist at the University of Miami. We just happen to be co-fellows together and sat next to each other for about a whole year. So we're very happy for all of you guys to join us today, and for those of you that will be listening to this as a recorded webinar. So the goal for the next hour is to do two things. One, to at least discuss how to set up and start an andrology practice. And number two, in your practice, what all should you be doing to try and succeed? And I know we understand most of you guys are fellows and trainees, and so this would be relevant to all of you, and you should certainly ask questions. Jason will go first and we'll discuss on how to find a job, how to think about setting up practices, whether you're going into academics or private practice. And then I will finish after that discussing the role of how do you actually run a practice, and what do you do for social media and marketing and so on. So I think that will be nice. And then we'll certainly take questions in the chat window as each of us are talking, and we're happy to answer questions in the chat window as we go along. And we're also happy to take questions both after Jason's talk as well as after my talk. And we'd love to have interaction, because this is really a practical topic. There's not one way to succeed. We're just going to show different ways in which this can be set up, but would certainly love to get your input and questions. But we'll start off with Dr. Jason Kovac.
Wonderful. Can you hear me okay?
Yes, we can.
Okay, all right. So I'm probably not going to be paying too much attention to the chat, and I'm just going to try and actually share my screen. So let's see if I can do that part of it. So let me try and do that. Okay, can you guys just see my, can you see my kind of title screenshot?
Yes, we can, Jason.
Good. Okay. All right. So my name is Jason Kovac, for those of you guys who don't know me, and girls. I am in Indiana. Specifically, I work at Urology of Indiana, which is a private practice group, which there's about 35 urologists, and we're kind of surrounding Indianapolis in both north-south or in north-south, east-west kind of areas. So it's a large private practice group. I started here, and the reason I found this location was when I did my fellowship with Dr. Lipschultz. One of his fellows was actually retiring, and that's when I came here about 9 years ago to kind of take over his practice. So that's kind of where I'm coming from. I'm originally Canadian, for whatever that's worth, but now I'm an adopted Hoosier, I guess. So what we specifically tried to do is we tried to keep the slides short, so we wouldn't take up too much of your time with just slides. And I think for both Ranjit and I think the key is going to be the questions that you guys have, you know, at the end. Open discussion. And these are just some things that I've kind of learned throughout going through the process of, you know, not only getting a job, but also keeping a job and growing the program, the men's health program, because a lot of you guys will go into a setup where there is no men's health present. So you got to try and figure out what exactly it is that you want to do. So first slide I want to talk about, I guess, is the first decision, which I kind of started thinking about. What, you know, do you want to do private practice or do you want to do academics? So along those lines, some of the questions that I asked myself is, you know, what kind of focus do you want to have? Do you want to go down a research track? Do you want to do clinical practice only? Do you want to do a mixture of those things? Can you do those things in private practice? I think the answer is yes, but it's very difficult to do. Responsibilities, you know, teaching residents, which I do as well. I mean, in private practice, I had a lot of residents go through. A couple of them have already kind of gone on to doing men's health fellowships, which has been, you know, fantastic. It's very rewarding to get that kind of, I guess, not respect, but just it's nice to, you know, have that. And Ranjit's also got tons of people who the Ramaswamy team who have kind of gone through there and taught a bunch of residents. We got to do grand rounds, M&M rounds. In private practice, you don't really have that. Benefits of being in academics as residents to do call. You can organize fellowships programs. Very difficult to organize very difficult to organize fellowship programs in a private practice setting. It's possible, but very difficult to do. We don't have residents that do call. Typically, if residents come by, they're just going to work with you for one day and then out. Benefits in national, international societies, you typically don't get as much exposure, even though you want the exposure when you're in private practice. Even if you did want it, it's still kind of more tied towards the academic space. Autonomy, ability to grow and focus. I think you have a little bit more autonomy when you're in private practice versus academic, but I'm not sure. I've only been in private practice. I've had the ability to kind of essentially do whatever I wanted within a limited scope in terms of what I wanted to focus on and also how I wanted to grow the business. But the truth is, whatever you decide, there's going to be issues. You're going to have to compromise. No job is perfect. So along with that, I'm going to talk about location here. Don't let the first decision be your guiding light, which is, I guess, a contradiction to what I just said before. But keep in mind all possibilities. Apply everywhere. Apply academics, apply private practice, see where you get interviews. Don't let the location hold you back. I don't know why this thing keeps jumping. Let me go back again here. Ugh, I'm giving away all my slides. There we go. So likely based on the decision that you guys have made in order to practice, in men's health, in ED, in infertility, you're going to need to be in a big city. However, referral patterns, lack of specialty physicians, lifestyle, family, these are all going to influence these decisions. First few years, in most situations, you're going to have to build your own practice. It's almost impossible to step into a men's health focused practice immediately. And that's what I had to do. You have to begin with seeing all kinds of conditions and branching out from there. And you do that gradually. I remember starting off and seeing everything, stones, all kinds of stuff. And then eventually you kind of get to focus, kind of refer what you don't, keep what you do want to focus on. Some tips that I've kind of learned: focus on doing the right thing. If you don't feel good about a surgery, don't do it. I've gotten referrals, especially in the beginning, from partners that are like, do this procedure. I don't think that's the right procedure. Now I have, enough confidence to say, I'm not doing that. That's wrong. But in the beginning, you're kind of like, well, this guy wants me to do it. He must know more because he's been out for longer. No, trust your training and do what you think is right. They're sending them to you for your opinion. Do what you think is right. Focus on the outcomes and not the time during a surgery. You really want to focus on getting good clinical outcomes, especially in your first couple of years. Don't rush. If things start to happen, word gets around and people start to talk about that. You want to make sure you get everything done properly, especially in the beginning. One thing that I struggled with, and I think a lot of people struggle with, is developing routines for how to treat certain conditions. So you get a guy with ED. Okay, well, what do? You get a guy with Peyronie's. How do you work through that? Not only, you're taught all of the different conditions, so you know what the treatment regimens are. It's more what the follow-up. Like, when do you get someone back? So you see somebody, when do you get their blood work? When they have the visit, how do you set up a follow-up? So all of those things take a while to figure out. Focus on your schedule, the timing of office visits. I don't even know what that means. Optimize her. Ignore that. Focus on your schedule and the timing of office visits. So basically, do you want a 10-minute schedule? Do you want a 15-minute schedule? When are you going to do your vasectomy? How long do you want your surgeries to be timed for? All of those things will take a while. Book longer than you need, especially in the beginning. Don't book an implant for an hour. Book it for 3 hours. Then if you finish earlier, everybody loves you. The nurses love you. The anesthesia loves you. If you book it for an hour, you take 3, you set everybody else back, that's going to be a problem. So don't do that. Make sure you respect the nursing staff, the place where you're doing the surgeries, as well as anesthesia, because all of that is going to come back later on and bite you if you don't optimize that properly. Find a location to do your surgeries. This took a while for me. I tried many different hospitals, many different surgery centers, and whether you can do that in academics, I think you still can to a degree. Everything is associated with different pros and cons, and you're never going to get the same team every time. Everybody wants the same team. Odds are that you're probably not going to get it. I have similar people that rotate even now, where I've been doing, I work in one surgery center, and I probably have a rotation of about 6 people. So 3 at a time. So now I'm at the part where I kind of do get the same team. but every once in a while they'll substitute somebody else in. So you just got to adapt. That's not a thing that's worth fighting for. So when I first started, 30% fertility, 70% general urology. Now I do 100% men's health. My main focus is male fertility. I do a bunch of varicoceles, vasoreversals, vasectomies, sperm harvest procedures. I also do a little low T. There's a lot of low T. You don't have to advertise for that. It's going to come. If you want to advertise for it, firefighters, police department, SWAT team, erectile dysfunction, Peyronie's, scrotal pain. You know, I didn't start with doing scrotal pain. I once mentioned it in a group meeting that I would do scrotal pain, microsurgical cord denervations and all that kind of stuff. And then I got inundated with scrotal pain. It's not as bad as you originally think. I have a paper that I put out. I follow the little flow diagram. I just follow that diagram. So if someone comes in, boom, 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 that's it. Hydrocele, spermatocele, just do those. They're so simple, they're easy, they're fast, and it gets you operative experience in an easy way. So what does our staffing look like? Right now, we've got 2 providers, myself and another MD. We got 2 physician assistants, one which primarily supports myself, another one which primarily supports my partner. The PA that I work with primarily does ED and low T. That's it. No infertility. I see all the infertility myself. I do not have a PA that does fertility. And I think that that's partially by design. I think that's important that you see all the fertility people. We have 2 nurses. One provides support for an MD and a PA. They also assist with post-op visits, pump teaching, injections, U-Wave. I think that's important to get set up in the beginning. Take some time to let the nurses learn what you expect from the post-op. I wouldn't, and I still don't send my post-ops just to see the nurse, because I think the patients want to see you. So it's okay, you know, later on, if you want to get them in for pump teaching. I see all my, I see the majority of my post-op patients myself. I think that's important. Lately with COVID, I've switched to doing all telephone follow-ups. So varicoceles, vasoreversals, biopsies, all that stuff is just a telephone follow-up, because frankly, you know, you don't get RVUs, you don't get paid to see follow-ups, and a lot of these guys are fine. I have no issues, knock on wood, on any of these people. Penile implants, I always see back.
Jason, just 1 second. You mean post-op visits we don't get paid for, so you do audio phone visits and not the follow-up visit, correct?
Yeah, yes, you're right. Post-op visits, you know, so I see my penile prostheses the next day or the day after. Those people I see. The rest, phone. And then, you know, you go on from there. But the post-op visits, the way that for penile prostheses, I used to do it in a hospital. COVID came around. I moved everything outpatient. So every single implant I now do outpatient. Support staff, 1 surgery scheduler, front desk, technician to do the seam analyses, ancillary services, which are sorted by the practice, Urology of Indiana. We have an ultrasound technician. It's not pending. We have one now. They come twice per week and they do duplex ultrasounds for penile Dopplers. We don't have fellow residents every once in a while, admittedly less in the past year. Advanced practice providers, PAs, the best thing for a men's health practice, in my opinion. I think Ranjit would probably agree with me. PAs are fantastically helpful in this type of a practice setting. Negotiate for one if you can. Alternatively, one strategy which you can employ is take over a current PA. Maybe not, you gotta be careful with this, but you know, initially go and ask them if they're interested in men's health. Give them some tips, give them some techniques that they can help with, and then send them all the patients that you can. If they like it, they'll continue to see them. If they don't, they'll let you know. And go that way. I mean, my PA told me in the beginning, he's not my PA, the PA. He told me in the beginning, he's like, I like low T and I like ED. Perfect. That's all he gets. And I think he's the busiest PA in the entire practice, and that's working 4 days a week. So, yeah, it's not really that important. Ancillaries. So, what's important for you when you get out? Number one, invest in a surgery center if you're allowed. If you can't, and if you can negotiate somehow to do that, it's difficult when you're moving into a new place. But this, by far, you'll thank me for it later. If you have the ability to invest in a surgery center, do it, 100%. Find one, and that's where it comes in with that stuff I was talking about with the surgeries, right? You want to make sure you respect the staff, because when it comes time to you being offered shares or being offered partnership in a surgery center, you want them to realize that you're a normal person, you're not throwing utensils everywhere, and you're treating people with respect, or else they will not offer you partnership in the surgery center. So that's very important. Consulting comes with time. Semen analyses, that's an ancillary. We still have a lot to go on that, but I like the way that we do it. We do it under insurance. You could do it as a cash service, but we don't make a whole lot of money on semen analysis. That's fine. It doesn't bother me. I don't offer any sperm banking. That's something that you can do, but for me in the beginning, it was a lot of risk. It was a lot of liability. It just wasn't worth it to set it up. Get the lay of the land with regards to what's happening around you, because if there are REIs that offer them, you can kind of turn them off if you start doing sperm banking in their backyard. So just kind of get the lay of the land first. On-site dispensary, this would be very dependent on what your current practice already has set up. And then duplex penile ultrasound, penile shockwave, we offer that as a cash pay service. And our nurses do the shockwave. So we started doing them. I did a few of them, and then now the nurses just do it all. So it doesn't even involve me. So next, billing coding, private practice. So we're in a LUGPA group, 35 urologists. This is kind of where you got to be a little bit careful for infertility-based things. So when I came in, the RVU rates for relative value units for andrology stuff was set to Medicare. So a vas reversal got me 8 RVU. For in the beginning when I started, it took me, honestly 4 or 5 hours, right? So you get 8 RVUs for 4 or 5 hours. So shockingly, my RVUs were significantly behind. But as you get better, as you get faster, you're still never going to make it at 8 RVUs, right? It's just impossible. So you got to try and negotiate different rates for RVUs. I tried to do that 7 years ago, haven't approached it since. And it's almost impossible in a male fertility practice with an RVU thing to make any type of general urology partnership RVUs. Impossible. If you can get them to do cash pay and associate cash pay with RVU, it's possible, but you'll be fighting an uphill battle. So that's just something to be aware of. These are kind of a few slides here that I put in that you guys can kind of look over a little bit later in terms of RVU for cash. So, I mean, you do a microtesty, takes about 2 to 3 hours. It's a last minute case. Something that you're going to want to get set up with immediately is try and come up with a good workflow for how to do these last minute cases, because they take up a lot of time. We're paid $3,000 around there for a microtesty, and I get 18 RVUs. Compare that to a cystectomy, which is a 3 to 4 hour planned case. You don't have to cancel anything. The planned case, and then you get 62.8 RVUs, but you're only generating, say, for Medicare, 2,500. So I mean, they're getting 62 RVUs, and you're getting 18. So something to be definitely aware of. Common urology cases are the same thing. Ureteroscopy, 49 to 79, prostatectomy, $50 to $81 per RVU, nephrectomy, $71 per RVU. What do we do with infertility cash cases? TESA, $360 per RVU, TESI, $323, and a vas reversal, $203. So I negotiated the best I could 7-8 years ago, but as you can tell from here, there's a huge imbalance, and this is a struggle that a lot of primary infertility practices deal with. There's been white papers to deal with that, but again, something to be aware of. I don't know the right way to go about negotiating it because I still haven't been able to figure out the right way, and it's a problem for me, and it's been 8 years later. So I don't have any answers, but I can just tell you to be aware. What's next? Wow, this computer is delayed. So you're usually going to be behind RVUs compared to general urologists, oncologists. More RVUs generated in clinic, but there's more money to be made in OR. Some practices can't account for dollar signs and are actually not really that interested. You don't get compensated for meetings to build a practice. You don't get compensated for vas reversal consults. I do all my vas reversal consults on the phone because there's people coming in from everywhere. I don't bill for those, but I get no RVU for it. So, I do 4 visits, 15 minutes each one. I get no RVU for it. Practice gets about, a good amount of money. I get zero credit for it. Research patients, IRBs, manuscripts, I get nothing. Ranjit's experience is probably a little bit different on all those fronts. Thinking some things about penile implants and vas reversals. Locally, your local competition is only one part of it. We're really talking about nationwide now, especially in this era. IPPs, guys are all over the internet. They're looking at these social media based practices. They're looking at high volume surgeons. So essentially you're competing with people who are all over the country. That especially irks me with vas reversals because there's family doctors, orthopedic surgeons, physician assistants of all things, conducting vas reversals. These are at ultra low price clinics, and they don't do, in my mind, a good enough job of telling the patients who they are or what their qualifications are. I think as a society, or as a group of people, we need to try and address this. And I think moving forward, this is something that's got to be looked at. Is there a role for our societies to do that? Who's qualified to do a reversal? Physician claims on websites are completely unsubstantiated. So it's something to be aware of. But in the end, be honest, and that will serve you in good stead. Impact of COVID-19 for myself. Before COVID-19, it was impossible to bill through insurance, very difficult. COVID-19 has been fantastic for my practice. I love telephone consults, telemedicine, absolutely fantastic. Hypogonadism for follow-ups. A lot of your people will be younger. They will change jobs. They will move everywhere. You can follow them for a short bit of time while they're transitioning to a different location and then hand their care over. It's easy for people. It's quick. Telemedicine is, in my mind, the best thing that happened to men's health for a long time. Next slide, please. I think it must be a delay in the internet. I talked about internet-based clinics. There are a lot of clinics out there that are doing primary hypogonadism management, and they're doing everything telehealth. So that's part of your competition as well. Medications, make sure you have a good grasp of the compounding pharmacies that are around you. For myself, I don't prescribe any medication from a compounding pharmacy where they do not let me go in and see the pharmacy. That's important to me. I want to make sure that they're not scam artists or charlatans. So anytime that there's a compounding pharmacy that approaches me, I want to see where they are, what they look like, and what their facility looks like. Obviously easier to do locally. Empower, I know from Fellowship, so does Ranjit, and Greenleaf is just a local pharmacy in town. I had about 3 or 4 pharmacies contact me. They will continue to contact you. A few of them, hey, can I come by and take a look at your setup? No. Will you prescribe our medicines? No. No, thank you. Right? No, thank you. It's ridiculous. Know the cost of the pharmacies and the cost of all medications. Believe it or not, a lot of us are very familiar with GoodRx paying for Cialis, fill, for example, $30 for 3 months. A lot of people don't know that. So you get a guy coming in, he's on Cialis, he says it costs him $300. You simply tell him about GoodRx and say you're going to whatever location you know is cheapest. The guy will love you forever because you just saved them like $500. So it's hard to negotiate anything these days. It's typically, in my experience, this way or the highway. And then you got to decide, do you want this way or do you want the highway? Invest in a surgery center, #1 take home. If your focus is on fertility, try and sort out the RVU issues. If your focus is on ED, set up a workflow that things get automated. The one thing I want to say with this is my PA sees all the ED. He gets all the referrals. Initial first patients typically go directly to him. He works it up just until the time the patient's ready for an implant, sends out the pre-authorization and sends the patient to me. I see the patient. Have you been explained about the implant? Yes. There's your pre-auth. Perfect. You're covered. Let's go. One visit to the operating room. Make getting in the PA a primary goal. Don't believe what you read on Twitter. Ranjit's going to get into this. Most of it just gives you FUD, fear, uncertainty, and doubt. A lot of junk on Twitter. And it just, I've cut back a lot on Twitter because it just drives me bananas. And then to quote the great Canadian Drake, you can't burn a bridge just to light my way. So keep your relationships good no matter kind of what happens, because you never know when someone's going to be able to help you. And overall, it's not worth being a prick. It's key. Just be a nice person. There's my social media. You can contact me for whatever you want. That's it.
Perfect. Thanks, Jason. That was a great talk. Guys, we'd love to take questions either on the chat, or if you are able to unmute your audio and speak, if you're able to show your video, also good. But we'd love to take some questions before we go on to the next segment.
Quick question, Dr. Kovic. In terms of investing in a surgery center, is that a move that you recommend someone does when they're certain where they're going to be living permanently? Or if you invest and leave that job, would you leave your investment there? Just a little bit about sort of the logistics of that, because that seems like a big commitment.
It is, and that's yeah, it is, and that's a great question. Typically, when you are given the option to invest in a surgery center, they're not going to give you that option right away. So most of the good places will take about a year or two to evaluate you and make sure you're not cuckoo for Cocoa Puffs. So you have some time. So if you're only going to be there for a year or two, I agree, it's not worth it. You know, typically the buy-in for those surgery centers is very expensive. So at least for the good ones. So you want to make sure you're picking a place where you're happy. And that's why it's important to go to multiple different places and check to see what the buy-in is and what the profits are for that surgery center, because you can have a huge buy-in and not a whole lot of money coming back. So make sure you kind of talk to people and get a sense. I was lucky in that I knew the guy who was there, and that was his main piece of advice coming to this place, and it's been a great place. But I did still look around and try and find different things, but it's going to take you a while to get to that point. And you're right, map out how long you're going to be there, what the initial investment is, and how long it would take you to recoup that investment. Typically, it's going to take you about 2 years of working in one place to get back the buy-in, obviously, depending on how much of a loan you have to take. Different places will do different ways. Some people have, they'll offer you 2 shares, 3 shares. Each share costs X amount of dollars, which is a good amount. Some will offer you 10 shares at a smaller share price. So you're going to have to look at calculating some of that.
Any other questions, guys? No?
There's something here in the chat, which I think you answered for, with the nurse practitioners and PAs. I mean, yeah. I'll tell you, in Indianapolis, Indiana, we have several practices that are nurse practitioner run and PA run, and you start learning who they are. And I actually, I guess this is being recorded, but I mean, this is fair. I think it's fair. I saw a patient a couple of days ago, and he actually knew one of the nurse practitioners in town, and this nurse practitioner tends to not warn people about the side effects of azoospermia before giving them testosterone. And I've seen multiple people from this individual with no sperm trying to have a baby, wondering why it's not happening. So I said to him very nicely, I said, listen, if this is your friend, please talk to her and please get her to stop doing this. So it happens a lot. A lot. Now, the other thing you can do, if I could just throw one more thing out there, is there are shot clinics that have reasonable people in them. All right. So you can go to some of those shot clinics and see if they're reasonable. Introduce yourself as a local urologist who does penile implants. See if they're considering, or see if they would consider referring you those patients that fail injections. You return the favor. You can send some of them over there. The guy who wants super trimix, quad mix with alprostadil, intraurethral, all this jibber jabber, send that over there. See if they could do something for him before he gets an implant. Some of them will send you stuff. It's possible.
There's one question about sperm retrieval and IVF, and I'll cover that more in my talk.
Oh yeah, I can answer some of that later as well. If you don't answer that, that's a touchy topic.
Any other questions? All right, we'll go on to my part of the talk, and hopefully we'll have about 10 minutes for questions again at the end. All right. All right, so we're going to discuss about two important topics today. It's basically how do you set up an andrology practice, and number two, to discuss about social media. I'd love to credit Justin Dubin for some of his slides on social media, and Ryan Smith for some of his slides on setting up an andrology practice. So basically, when you're going to go into a practice, they're going to ask you, they're going to give you rooms, and obviously you need to have patients before you could start getting rooms. But anytime you know the rooms are what is limiting you from seeing number of patients, don't hesitate to go and ask. They're always like, oh no, if you have X number of patients, but if you always need more, feel free to go ask more. But when you're starting practice, don't be like, I need 3 to 4 rooms. So use that judiciously. And clinic, in terms of OR, they're going to ask you the question, how many clinic days and how many OR days do you want? I think asking for 2 clinic days and 2 OR days, in the beginning, maybe start with 1 OR day and maybe 2 admin days, and use one of the admin days to go market, to go discuss. We talked about REI relationships, men's health, practice relationships. Use one for practice building and growth, and one for admin day, because now when you start practice, you're returning all the patient phone calls, you're following up on all the labs. You really don't have much help in terms of ancillary staff to help you out when you start the practice. So maybe 2 clinic days, 1 OR day, and 2 admin days is a good place to start, and then grow from there on. Obviously, here at the University of Miami, we have a pretty strong fellowship program, as well as nurse practitioners to help us with our clinic volume. Staffing costs, they're going to ask you, who do you want to get help from? Just need to know how much all of these people cost. An advanced practice provider is around $110,000 to $120,000 with a base salary of around $90K. Medical assistants can do a lot for you if you actually train them. They can call in prescriptions on your behalf. They can follow up on results and send you only the abnormal results. They're happy to move the schedules around. They're happy to help you in clinic. Really well-trained medical assistants, around $30,000 to $40,000 is sometimes really where you guys need to start with. Don't shoot for, I want an NP and a PA written in my contract. And somewhere in between the two is an RN. And sometimes RNs work very well because they are able to, again, do a lot of things that you want people to help you out in the back end, putting in orders, following up on labs, calling in prescriptions, refills, prior authorizations, all of those things. But it's important to remember, all of the people can do all of those tasks. And you don't necessarily always want to get an APP and a PA or an NP to do that, but sometimes it can be expensive. If the APP is actually seeing patients and helping you generate revenue by letting you see more new patients, letting you be in the OR more, take care of post-op visits. Our post-op visits are all seen by our nurse practitioner, Leo Ramos. I think he's on the call. I usually talk to patients at the end of surgery, and then if there's an issue, I go back and see them, and we see them back in clinic. But if there's no issue and if it's straightforward, we just let the nurse practitioner take care of it. So remember that these are the salaries, and figure out what you actually need help with, and make sure you ask the appropriate staffing for what is needed. Don't just say I need an NP or a PA to start. Should you go to more than one site in clinic? There's some advantages and disadvantages. I go to 3 different sites to see patients. Patients want to be seen where they live. They don't want to travel. They don't want to pay the toll. They don't want to pay extra parking. And if you go to satellite clinics, you're able to see patients away from the main site, where you probably do all your procedures and the office procedures. And this way you can just do office visits wherever you go. Obviously, going and seeing patients in a different catchment area is obviously very different. Referral practices will be very different. It can vary from county to county. And so certainly think about it. If the practice offers it, maybe start with 1 extra site. Don't commit yourself to going to 4 to 5 sites when you start practice. That's ridiculous, because you can never set up ground and referral patterns in any site. So start with 1 extra site, and obviously as you grow, figure out where else the needs are. Obviously, the disadvantages, now you're basically going to different places. You're trying to set up the whole workflow of orders, prescriptions, compounding pharmacies, refills, all of that in different sites. So it takes a lot of work. So it's not just like, I'm just going to go there and see patients and everything's just going to happen the same way where you were, unless you take personnel from the main site with you to those sites, and then they understand the workflow and they can help you out. So advantages and disadvantages. My best advice, start with one extra site if the practice offers that. Don't stretch yourself too thin by going to 5 sites. Jason spoke a little bit about andrology. We actually set up our own andrology lab, even though there was an IVF center on campus at the University of Miami. It is a cash-based practice. We charge $200 for every semen analysis. If it's a follow-up semen analysis and we don't do morphology or viability, it's $100. So when you go to practice, call around the area, call IVF centers, figure out how much they charge for semen analysis, and see if it's worth your time and the technician's time to be doing it with cash and or insurance, like Jason spoke about. But the ability for us to be able to get sperm analyses on the same day. We also do sperm freezings because we started the fertility preservation program here at the University of Miami, and we didn't want 12, 13, 14-year-olds newly diagnosed with cancer with their parents go to an IVF clinic where all the couples are being evaluated. So we wanted to make this truly a urology experience, and we set that up. Yes, a lot of legal regulatory barriers that we had to cross and overcome to be able to set that up. But I think it's a very nice service that we're able to offer patients, especially if you have large cancer centers that don't have the ability for fertility preservation. This is a great service that you can offer. We didn't do this, but we bought an in-house sperm DFI machine that we are now going to start doing it in-house once we validated all the controls. We used to send them out to a local site that basically followed the SCFA, the Don Evanson's sperm chromatin fragmentation assay. We're trying to do a COMET assay and validate that, so we can start doing this in-house as well, so we can get the results a lot faster and not having to wait for 2 to 3 weeks to get back to the patient on what the sperm DFI is. So again, you want to think about how busy your infertility practice is going to be and whether all of these are going to be valuable to you. If it is not, and you're not going to be doing it on your own, you have to figure out a way on what you're going to do, where you're going to do these things, because you want to talk to your patients and let them know some sort of a solution on what that plan looks like. Like I said, we do offer sperm banking. It's $450 for the first year. If you have the Live Strong benefit, if you're below the poverty line, then it's about $300 for the first year, and then $75 every year thereafter. We only do short-term storage, so the most you get 2 to 3 months at the University of Miami, and then we ship this long-term to Reprotect, and Reprotect sort of takes over. So the liability of holding sperm samples longer than 2 to 3 months doesn't exist with us, and we're happy to do the initial freezing so the patients don't have to travel far or go to IVF centers to do these things. Whereas the long-term risk and liability is not there with us anymore. We spoke a little bit, and there was a question about sperm retrieval and how do you coordinate with IVF centers. I think this is a very, very, very important relationship if you're going to practice andrology and have infertility in your practice to set up. Like that extra day that I said in your week, in your first 4 to 6 months, in addition to the admin day that you had, I made it a point to basically go to almost every IVF clinic here and introduce myself. Some residents used to make fun of me saying you're like a drug rep growing from IVF center to center. That's exactly it. We urologists, you're going and waiting for an hour or two to meet with a gynecologist. But unfortunately, that's the way it works. Very nice paper by Matt Coward and FNS showing that reproductive endocrinologists are the gatekeepers of male fertility patients. That's why patients show up. And you want their support to help grow your fertility practice. And so certainly establishing that relationship can be tough, can take a while. They're not going to send you patients after the first visit, maybe not after the second visit, maybe after the third or the fourth time that you've seen them around and they sort of know, they've heard your name from a few patients here and there is when they're going to start sending you patients. So that takes a while because that's not a relationship we're used to working with very well in the hospital. We always hate gyne consults. And so this is something that we all have to work on, but very important. and you want to coordinate. There's a lot of coordination that needs to happen, especially if you're offering fresh sperm retrieval. Where is the sperm retrieval going to take place? Who is going to take the specimen? We have a surgery center that's about a few miles away from the IVF clinic, and we have biological transport courier set up from the University of Miami to basically take the sample over to the IVF clinic. So a lot of coordination. We have IVF calendars set up that coordinates between the IVF center and us, knowing which patients are going to be on what sperm retrieval date, if it's a fresh versus frozen. But all of those things are all things that you want to think about. Talk to your IVF doctors when you meet them, because you want to come up with some sort of a plan and know that you're going to understand that all of these problems exist in setting up a good and a robust male fertility practice. I think Jason spoke a lot about billing and coding. This is just so unique to andrology, just because we are heavily still rely upon a cash-based practice. Thankfully, the SSMR white paper that Jim Dupree published is a very good guideline. We at the University of Miami actually took one of those guideline recommendations and are now converting the dollars per RVU based on one of those guidelines. So we basically convert, if it's $45 per RVU, 10% of that goes off to overhead, and the remaining 90% gets converted to work RVU. So something that you need to think about to negotiate. Jason spoke a lot about trying to discuss that upfront. You have to discuss that upfront. And this is going to be discrepancy if you're an RVU model. If it's a cash model and you're getting dollar for dollar and you're getting compensated, and that's how you're going to be given bonuses, that's fantastic. It's very easy. You'll make a lot of cash running a busy fertility practice. If it's an RVU model, you just want to make sure that you get buy-in from the financial person, if you're going to an academic department, the chair of the department, and make sure that they're on board. But thankfully now there is some sort of guidance from the SSMR that we can use. How much do you charge for sperm retrievals and vas reversals? Really regional standards. National standards, tough to match. As low as $2,500, people can get a vas reversal. Some places can go up to $25,000 to $30,000. But regionally, just call a few people, say, hi, Mr. Jones, I'm trying to get a vas reversal. How much do you charge? Figure out the prices, and then see what you want to charge based on what's in your region. We spoke a little bit about this, about dollars per RVU. The one thing that you can use, and we've used this routinely, is called the 55899, the unlisted CPT code for all GU procedures. And so usually that's what I use to code microtesy. And basically we convert the dollars per RVU. So if it's $2,000 cash from the procedure, and if it's $50 per RVU, you can get 40 RVUs for those cases. And if it's a collection model, usually 1/3 goes to the facility, 1/3 goes professional, and the remaining 2/3 goes to the facility fee. And obviously you have to put some money aside for anesthesia as well in a collections model. So remember the 1/3, 2/3, they're going to ask you, doc, okay, so you're going to charge $6,000 for the patient. How much do you want the hospital to take? So it's $4,000 for the hospital, $2,000 for productivity fee. You're going to be like, how much do you want to give anesthesia? $500. So the remaining $1,500 should come to you. So get some sort of an idea in your head, because they're going to ask you. If you're the person that's going to go start this program, they're going to ask you, and you can't say this is not something I don't know about. If you don't know about this, please ask your fellowship director where you are at, what they do, and ask around. Ask other fellowship directors, ask people in practice that have set this up, figure out all the models that exist, and then present all these models if they are successful to your practice, and make sure that you get something. Getting no RVUs, I think, is just a horrible thing. Getting the standard number of RVUs that Jason spoke about, the 12 for vas reversal and 3 for microtesy, I think it's just very unfair. And if that's what they're presenting to you, you got to think about twice about taking the job or staying on in that job, because it's just an unfair model, and you're never going to meet your targets based on some of the salary figures with AAMC. We spoke a little bit about ultrasound. Jason spoke a little bit about this. If you have a very busy ED Peyronie's Perdices practice and you are doing ultrasound, you can get a technician either half a day a week, or 1 day a week, or 2 half days that patients can schedule. And as long as you are in the facility while the ultrasound is happening, even though you haven't seen the patient directly, You can still read the ultrasound report, look at the images, and still bill for it. But make sure that you are in the facility. You can't be at home doing telehealth and charging patients wherever they are. And again, andrology lab, that's something that you want to think about depending on whether you have easy access to an IVF center and you're seeing patients in an IVF center. Don't go start an andrology lab on your own. But if it's far and access to care is an issue for male fertility patients, then certainly think about starting your own to have this as an option for your patients. We spoke about this already. And finally, insurance authorization. This is just a big pain. One of the biggest problems that we have is for penile implants, if we're doing this routinely in practice. Thankfully, both Boston Scientific and Coloplast have programs with them that will help patients get insurance authorization. These are HIPAA-friendly programs. Please speak to your rep and/or the regional manager. They'll connect you with the appropriate personnel within the companies that can help you do this. Endopharmaceuticals, if you're going to do Xiaflex and Avid in part of your practice, they have a third-party verifying system that you don't need to buy and bill. You're able to let them handle the insurance, and you just handle the professional part of the fee, so you don't need to worry about not getting paid for the drug. Certainly, these are all these are all unique things that to andrology that doesn't happen in the general urology field. You can't go ask a female urologist or a stone specialist or an oncologist any of these questions because they're not going to know what you're talking about. And that's why it's just important to know that these are all things that you need to be thinking about learning during your fellowship. If you haven't learned it yet, go back and learn it. I highly urge you to do it. Figure out what's happening in your practice. Speak to fellows around the country. This webinar is so nice for all of you guys to interact with each other. How do they do it in other programs? What does their mentor do? How do I learn this? Ask questions. Don't feel free to ask questions, because only when you ask are you going to learn all these things. And then figure out what's going to work for you in your practice and your group and or hospital where you're going. So the key message that I think that me, both Jason and I have communicated today should be to ask questions and learn, because this is the time for you to learn, not when you start practice. Because when you start practice, they're going to ask you all these questions. And if you don't have answers, they're going to assume something. And more likely, they're going to assume it in a way that it benefits them and not you. So just make sure you're aware of all these things before you go. And finally, really don't rely on EMR for your coding. I think the key is make sure you're billing appropriately, coding appropriately. We're not coders. We're never trained to be coders. Your fellowship mentor will be doing one thing, but just make sure that you ask your mentor how they code, what level of services do they do, how do they code for certain procedures, and certainly once you start practice, speak with your coder if you're doing things right. You may be over coding, and that's fraud. So just make sure you're coding appropriately. And I think Jason spoke about telemedicine. I think it has become very, very invaluable in all our practices, especially with men's health. It has become so well accepted both by patients and doctors. And it's, I think, very, very important that you make this part of your practice. And at-home semen analyses have become a thing. There's lots of companies now that are now taking over the male reproductive health space. Just remember that all of these companies are also trying to take patients away from us. Hopefully, this will enable people to get interested in their male fertility early on, and this will only increase the patient volume that we see. I just don't know how all of these are going to go, but just nice to know that, finally in male fertility, there are now companies that are interested in getting patients, and increasing awareness among patients, I think, is key. It's probably good for the field, but more to come on this one. And finally, I'll wrap up with social media. I think the best thing that I think Jason did mention, social media has a lot of ills, it has a lot of benefits, but the key is everybody is on it. Just you have to position yourself as the experts. Really, reputation gets built on social media. You can easily create a bad brand. You can create a good brand, and I think the key is to make sure that you build a good brand. Not all is well in social media. Really, there's lots of drawbacks. There's negative repercussions. There's lots of fears on social media with bullying and patients saying bad things. And basically, I think Twitter is probably a very good platform to communicate with peers. And at least I use Instagram and or TikTok for communicating with patients. Make sure you get a handle. It's professional. It's consistent across all platforms. Promote your practice, promote your research. Really do it for the good. If you're just promoting it just for the sake of branding, then it most likely will end up being bad. And finally, if you probably have to ask someone, can I post this? Then probably don't post it. All these posts remain forever. Even though you delete them, that doesn't necessarily mean they disappear. And you really represent your practice, your institution, your hospital. It's not just you, unless you're in a solo practice. So whatever you're doing, remember, it reflects on something much bigger than what you're doing. If you're going to text something, don't post it on social media. This is not replacement for texts. And really be careful about providing medical advice, because all of these can be legal liabilities. And finally, to finish off, I think what works for really someone else, not necessarily work for you. Figure out what's best for you, your practice. Clearly, you've seen two different models, two very different practice patterns, and really don't keep chasing clout. I think Jason mentioned this in the beginning few years. Make sure you put your head down, do the good work, don't have complications, don't take on risky patients, and the reputation, once you build it, will happen, and patients will come and find you. And finally, a plug, Jason, Ryan Smith, and Liebert Ramos, my nurse practitioner. Hopefully the AUA in New Orleans happens this year, but the SMSNA has obviously selected us again to do a live course on May 14th in New Orleans. So if you're there, please register and attend. We'd love to see some of you in person. And finally, thank you all for attending, and happy to take questions for the remaining few minutes that we have.
I think there was a question on the chat. Are there certain aspects of your practice that you emphasize a cash-only basis for? What's the role for cash-based and digital health? Do you have an answer for that, or do you want me to touch a little bit on that?
You can answer that.
Yeah, I mean, vasectomy reversals, insurance, nothing. I tried it in the beginning. They all got rejected. Maybe for scrotal pain, you have a chance, but I'm not taking that chance. So if you want a vas reversal even for scrotal pain, pay cash, we'll give you a receipt, and then you can claim that later. So I don't take any insurance for vasectomy reversals. Sperm harvests, typically it should be cash before you do the procedure. Every time I do a consultation, I tell them the costs of what it's going to be for my part. And then I also add in that there's going to be a cost for anesthesia if you want it, or there's going to be a facility fee. And depending on where you do the procedure, that's what the facility fee is dependent on. So, you know, I travel around to different facilities. So I don't know what the costs are of that facility. Talk to that doctor, that repro endo, for the cash price of that. And then cash-based and digital health, telehealth, all of the telehealth that I do is insurance-based, except for the vas reversals, for which I get paid nothing. We played around with the idea of charging people for consults for vas reversals. I don't think it's a good idea. There's a lot of people that are doing them for free. Mostly everybody does them for free. So I think you're going to lose patients more so than gain anything by charging people to talk to them. But telehealth for me is all insurance based. Implants, yeah, I have a cash based quote that I'm able to give the patients right away if they want to do cash based. Same with for all my procedures, because I do a lot of the stuff in the surgery center. It's easier to work with the surgery center to come up with a cash based cost, and then I bundle it all together: insurance, anesthesia, facility, and my fee. And I know them off the top of my head, so I could tell people what they are, so that there's no surprises. And sometimes anesthesia will bill them twice, facility will bill them twice. So I try and tell all the patients, listen, if you get billed twice, call me, because I don't want you to get hosed. That's not the point of it here. You know, call me. Things happen. And being upfront like that usually, for me, has been helpful.
There's one question on office versus ASC-based fertility procedures. So in the office, all that we do is a TESA. You can't, for a TESA, there is a CPT code, so you can't charge the unlisted code. So 54505 if you're doing a TESI, or a 54501, I think, if it's a TESA, and it's either $1,000 or $1,500 based on what your local rates charge. So that's easy. And then for all the ASC-based procedures are vas reversals, varicoceles, and microteses and mesas. So, but obviously all those are, we discussed the cash prices for those, and that's different. So that's
the only stuff I do in my office is patients who have vasectomies and are on testosterone, and they need to assess their fertility potential by just doing a TESA. I'll do that in the office. I try and direct everything else to the surgery center.
Got it. Any other questions, guys? Sure.
I was going to ask, and either one of you can answer that. And it's not so much practice, but it's sort of overall, as you were stepping from training into the role of a consultant, and you're looking at a lot of money coming in, and maybe some tax complexities, and a lot of these things that you guys talked about, a lot of us are still learning. In terms of getting a coach or having a mentor, and all senior physicians are busy, right? So how did you go about kind of asking your questions and sort of getting to learn how to be where you are right now?
That's an excellent point. So people in your practice are probably not going to help you, not because they don't want to help you, but just because they don't know how to help you. And really the way to ask questions is to people on this call, or your mentors, or anyone else. Like people that are going into practice with you. We're all on this call. They're all going to be graduating this year and going off into practices. Give them a call. Be like, hey, what are you doing? This is what I'm having difficulty with. What did you end up doing in your practice? And then they may connect you with someone. And that's how we learned, we talk to each other. I used to call Jason. I'm like, Jason, what are you doing for TESAs? How do you do TESAs? He's like, oh, I do 10 passes with the needle every time. I'm like, okay, great. So I started doing 10 passes with the needle. You know what I mean? So we learn, I think most of this stuff we learn from each other, not from people in your practice.
Oh, yeah, I can't tell you the number of times that I've called Ranjit, or I've called any of my co-fellows, and I'm like, hey, listen, like I got this case. I just don't know what to do, or like, what would you do? And then even just talking it out is such a huge help. I know for me, I mean, if you got my email address, feel free to drop me a line. If you want to chat on the phone, I'm always willing to do that. And honestly, one thing that I found, which takes a little bit of time, but I like to discuss all options with the patient, and I talk through a lot of what I do, why I do it. So there's a lot of complicated cases where, a guy, whatever, CF carrier, he's got azoospermia, he's from far away. Well, okay, does he have vas deferens? No one's there to do a physical exam. So talk it out, tell them what the options are. Say, look, it could be this, it could be this. I don't know. If we do this, then this is what's going to happen. So involve the patient in your decision-making as you're learning to do it yourself, because I find that helps. I do that a lot now. Now that I've got a good grasp on the way I do things, it makes it a lot easier, but I find that helps. I think patients appreciate it. Bad part is it takes some time, but I think they'll be grateful for that.
Quick question regarding what you were saying before, Dr. Kovac, about selecting certain procedures or things that you charge cash for, where mostly it sounds like you're working with insurance. Can you foresee, or could you kind of imagine a model where you're mostly working with cash and then selecting some things to take insurance for? Because you need the staff and the people to help with your contract for insurance and billing and all of that. Is it ever conceivable to do it the other way around, to mostly take cash and then accept insurance for certain things?
I think there's some legal issues with regards to cash and insurance, and what you can bill for cash and I don't have enough background to be able to give you a good solid answer of why you can do some things one way, but not another way. It's easy in the fertility space because you can say, well, this is the price. It's all cash based. All fertility is cash based. it's easy for patients who don't have insurance, but can you double dip? You can't. So you can't bill someone for insurance for one thing and while still charging them. So can I see, can I say, okay, for a patient, I'm going to treat your hypogonadism and you're going to pay me $2,000 a year for my personal time as your, priority kind of physician. And every time they see me, I bill insurance for that. You can't do that. You'll get in a lot of trouble. But I know that's not what you were saying. But.
Yeah, I'm just curious because there are a lot of the female sexual dysfunction things that I do are not insurance covered at all, aren't even like recognized by insurance. So that would be an interesting thing to try to be able to also accept insurance for certain patients and for a lot of what I want to do, but still have to charge cash for things that aren't covered by insurance or aren't even.
You can do both.
Yeah,
you
okay.
could absolutely do both. I mean, as long as you're not double dipping, you should be fine. If you're going to go into private practice by yourself, that's a different issue. But if you have people to help you with that, then yeah, absolutely talk through all that with them. And that's what I do. I do a lot of stuff on their insurance, but at the same time, I also do a lot of stuff that's cash based.
Sure. Yeah. Thank you.
I have a quick question, last minute, if you don't mind.
Sure.
In regards to using APPs in the clinic, what procedures do you feel comfortable with them doing? And if you have had them do them, have you then gone back to doing them yourself because of differences in reimbursement and or complications?
Libert Ramos is on the call, so he knows. So he does Testopels, Avid, some Xiaflex patients that can't fit in my schedule, and ICI and ICI teaching. So all of that is fair game. And then I'll leave it up to, and we've had no issues if there's complications. He tells me about it. We all get complications. I don't think it's any more that as long as it's well trained and they've seen it, that should not be a reason for you to stop letting them do something because of one complication or one rare complication.
Yeah, I think my PA's practice is very similar to what you're describing, those types of things. Can you get them to work at the edge of their license? Do you want to push that? Having PAs do cystoscopies, I don't think it's unreasonable. If I do a cystoscopy pre-penile implant, I think if I had a PA that wanted to do that, I'd be pretty comfortable with that as long as they're properly trained to do it. But am I comfortable with a PA doing a vasectomy reversal? I don't think that should happen under any circumstance.
Got it. Guys, with that interest of time, thank you very much for the engaging questions. Thanks to SMSNA and Bobby for hosting this. Wish you all good luck in your careers, and absolutely, like Kovac mentioned, please stay in touch, talk, learn. It's the only way you're going to learn is by asking questions. So good luck and good night.
Thank you.
Thank you, everyone. Have a great evening.